So, this is our second and last mini lecture for the week, and let's start by talking about microaggressions. Microaggressions are subtle forms of isms related to race, sex, age, sexual orientation, and other things. They're not these huge racial disparities that we're talking about that are big and noticeable and very overt. These are the everyday insults, indignities, and demeaning messages that people, a person, or a group might experience often that keep on just niggling at them. They're small incidents or indirect insults. They can be intentional or unintentional. And with this, the burden can accumulate. And we talked about this when we talked about stress a few weeks ago. The idea of an allostatic load, that the most important and most detrimental type of stress are these things that just keep adding up, things that get out of control because they're just everyday incidents. Examples are like feeling like you're being followed in a department store because of what you look like. Somebody asking me when I was younger and saying, "Are you Jewish?" And then when I jokingly said no, they said, "I'm sorry, I assumed you were Jewish." Like assuming something and thinking that was a bad thing. Somebody telling you you're very articulate for whatever group you're from because they wouldn't imagine that somebody from your group would be so articulate. There is something called the Everyday Discrimination Scale, and there are many ways now to measure microaggressions, and some of them have been developed for specific groups so that they actually address some of the issues that people are experiencing on a daily basis. So this one's just a general one, and some of the questions have to do with how you're treated, such as less courteous than other people or with less respect, that they might receive poor service than other people at restaurants or stores. People act as if they are thinking that you're smart or not smart. If they're afraid of you, they think you're dishonest or are better than you are. And a part of the discrimination scale is that people are called names or insulted, or they're threatened or harassed. So when people say never to almost every day, you can kind of get an idea of how much discrimination and how much micro discriminations they're dealing with. And therefore, you might understand what health effects there will be from this daily, day in and day out discrimination that people are experiencing. We talk a lot about race, but there are other groups that are stereotyped and have discrimination and prejudice against them. And for an example would be the overweight or the obese. People in the overweight or obese group have described themselves as being the most discriminated on a daily basis just for how they look and what people think. So you can think about some of the stereotypes that have to do with obesity and being overweight. And what I've read about is like people think that people who are overweight or obese might be lazy, less intelligent, not successful, unattractive, not likely to be in a relationship, mean, or jolly. I'm sure there are many, many other stereotypes that are out there. So in one study I read, many obese women face stigma every day. And so 50 women who are overweight or obese were asked to keep daily entries into a diary for just 1 week, just 7 days. And in those 7 days, for 50 overweight or obese women, they accumulated over 1,000 stigmatizing events. Daily insults included humiliation from strangers, family, and friends. Stereotypes that they wrote about were that they had less stamina and drive, that they were lazy, less competent, and less likable. They reported physical barriers, nasty comments, being stared at, and negative assumptions of others. And then they talked about what the impacts were. And they included isolation, low self-efficacy, low motivation to exercise or eat well, and the daily burden building up. So this study was conducted by the Women's Health Across the Nation study. It's called SWAN, and it was a multi-site longitudinal epidemiological study designed to examine health of women during their middle-aged years. And so the study examined the physical, biological, and psychological and social changes during this transitionary period. And so this part of the study focused on working with obese and overweight women. Minority women have been found to receive worse care than other women. And this recent study in 2015 found that minority women got worse breast cancer care regardless of their tumor type. So they looked at records of over 100,000 US women. Regardless of their insurance status, minority women were more likely to be diagnosed at a later stage in their cancer, diagnosed at advanced stages in their cancer, less likely to receive recommended treatments, and more likely to receive substandard care. And you just have to say to yourself, what is this all about? But we're saying here, what we're finding here is that this is regardless of insurance status. So it's not like people who only had no access to care or people who couldn't pay for their care. Regardless of insurance status, these minority women had poorer health outcomes when they had breast cancer care. Experiences of discrimination are associated with delays in seeking treatment, lower adherence to treatment recommendations, and lower rates of follow-up. It's called loss to follow-up. So somebody might say, I'd like to see you back in 2 weeks or whatever. And then these people who have been discriminated against or feel like they have been are less likely to show up for their appointment. When I was working in North Carolina with African American breast cancer survivors in the very, very rural part of the state, I asked them about, we were trying to figure out what are the experiences of people who have breast cancer as African American women in this part of the US. And we found that for them, there were stigmatizing beliefs about having cancer in the first place, cultural beliefs about African American women being very, very strong and not getting sick. And there was racial discrimination in the middle of everything. One woman told me, we have doctors that come from the North and doctors that come from a foreign state. They are real nice to us, you know. They don't see us as being Black folks or African American people. They see us, look at us like human beings because they're sort of prejudiced here. And another woman agreed and said, not sort of, they are. So in the middle of going through breast cancer and other life events, they're dealing with racial discrimination all the time. So what are the health consequences of these isms, these day in and day out assaults on you just because of the group that you're a part of or what people think you look like or should act like? Like I said, there's isolation, there's differential access to quality health care, differential treatment within the healthcare system, like we saw with the women with breast cancer. There can be poorer health outcomes when they are treated, and then poorer quality of life. For these people, there's often accelerated aging, and there's often a lower life expectancy. Why does this continue? Well, many of us have heard about the Tuskegee study of untreated syphilis in Negro males. It was a public health service study. The whole idea at the beginning of the study was trying to find rationale for offering poor African American people health programs. But then it turned into this sort of ends justifying the means type of study. The study began in 1932. There were 600 Black male subjects. Over 300 of them had already had syphilis and others did not. They were told that they were being treated for bad blood. They weren't told about syphilis, and they were not told that at a time that they really weren't being treated for anything. They were just taking their blood and testing it and seeing how people with syphilis actually developed their disease and how they progressed with it. The idea was to advance science. They were not being treated at all. And even though there was penicillin, which was discovered to be a great treatment for syphilis, they were not offered this easy treatment. The study was not stopped until 1972, 40 years later. This has been instrumental in the mistrust of our medical system for many people, including African American communities. You can just imagine. Due to mistrust in the medical system, this can result in an underutilization of preventative and timely care, postponing needed care, lower satisfaction when you do get care, poor adherence to medical recommendations, because why should you trust your doctor who might not be looking out for you as well as they look out for others? Because of this, there's poor self-management of chronic conditions. There might be that loss of follow-up, which we talked about in an earlier slide. And then there's lower participation in clinical trials. Clinical trials are overt research projects that try to get people who are dealing with things to go in for some kind of clinical research to try to advance the science. This is something that people consent to do, and it helps to understand what are the issues and what are the possible ways that we can treat certain issues. When we have poor participation in clinical trials, there's no advancement in research, or the only advancement will be with people who are from majority populations. And therefore, you won't learn about and you won't understand, and we won't be able to actually advance science for people who are not from these major populations. But what can we do? What is being done, what should be done, and what can be done? The major thing is to keep in mind that we can't just focus only on the patient, the individual. Just because of their racial group doesn't mean that we can have prejudice and discrimination and self-blame or blaming individuals just for who they are and their reaction to how they might be treated. We have to think about the patient, the provider, the healthcare system, and the population-based policies that are the root causes for these issues that people in lower population or minority population groups experience. People need access to the medical care they require. We need to cultivate a therapeutic alliance between the patient and the provider and the healthcare system. We need to ensure that there's a safe learning environment for people who are patients, for providers, and for new medical trainees. We need to enhance internal motivations to reduce bias and avoid external pressures. We need to increase understanding about the psychological basis of biases that people have with regard to other groups. We need to enhance providers' confidence in their ability to successfully interact and socially interact with people who are dissimilar to themselves. We need to improve our ability to build partnerships with patients. So again, we need to use the biopsychosocial system or the public health social ecological framework to address not only the individual, the patient, but also the system and the population-based policies in which they get their health care or try to survive and thrive. So that's all I'm going to talk about right now. And again, please think about next week your posters. And I'm going to give you a few examples of posters right here. And I'll share that in another video.